It's a huge pleasure for me to introduce Professor Sir Anthony Newman-Taylor, and Anthony's going to introduce the presentation, and hopefully Joanna will have joined us by the time it's her slides appear on the screen. So thank you very much.
The question that we are addressing in this seminar is, how do we know interventions work? Could I have the first slide, please? So we make interventions in order to make a difference for the better. But without evaluation, we do not know whether or not they have been effective. We don't know whether the intervention has had the intended effect or whether it has had unintended or unanticipated consequences. Scientifically, the fundamental question that we need to address is a comparison of what has happened with what would have happened in the absence of the intervention. So this is no different both from etiological research or from randomized controlled trials, where we are essentially asking the same question by comparing the outcome in the therapeutic or preventive group with a comparison group, the control group. Next slide, please. So the most reliable way to answer this question is through the randomized controlled trial. And the strength of the randomized controlled trial is the investigator has control of the assignment of study participants. We can distinguish clinical trials where the comparison is made between individuals from cluster trials where the comparison is between groups of individuals, such as workforces or departments in a workforce. Clinical trials, however, have problems in the context of workplace interventions. They're often not feasible in the context of a workplace, and they may be unethical in relation to a recognized hazard. We do not compare the outcome of control of asbestos exposure with leaving asbestos exposure unchanged when we are aware of the potential problems of asbestos exposure. So for these reasons, cluster trials and quasi-experimental designs are commonly used in workplace studies. Next slide, please. Now, evaluation of interventions test both the efficacy of the preventive or therapeutic measures, as well as the validity of concepts of causation on which the intervention is based. And when an evaluation suggests or indicates that the intervention has not been effective, it is either because we are incorrect in our concept of causation, or we have the preventive measures that we have put in place have not been undertaken effectively. And frequently distinguishing these two between these two can be complex. I would like to start off with an example of this. Could I have the next slide, please? So in a meta-analysis of the relationship between low back pain and occupational exposures, Lotters and colleagues identified a number of established risk factors where the risk of low back pain in occupational groups was greater than in a comparison group. And the established risk factors which had the highest risks were manual materials handling and frequent bending or twisting, in both of which cases the risk was greater than 50% in those undertaking these procedures at work as compared to others. So based upon this, it is plausible to consider that ergonomics interventions which would improve the consequences of both material manual materials handling and frequent bending or twisting should be expected to reduce the risk of these occurring in the workplace, or low back pain occurring in the workplace or attributable to workplace exposures. Could I have the next slide, please? However, in a systematic review of 10 randomized controlled trials, Dreesen and colleagues found that only low to moderate quality evidence that physical and organizational ergonomic interventions were no more effective than ergonomic interventions on short and long-term low back pain. And in 3 of these studies, which included nearly 1,200 participants, the prevalence of low back pain during the period of study was no different in the intervention group from the control group. So the arguments which followed this were based upon whether or not the failure of the intervention was because workplace manual handling, frequent bending, and other factors were not causative in the incidence of low back pain, or whether the measures that have been put in place, ergonomic measures put in place, had not been properly followed. Either way, there is no evidence that ergonomic measures to improve workplace, undertaken to improve the risk of low back pain in the workplace are effective. Could I have the next slide, please? So I'd now like to move on to so-called quasi-experimental designs, where there is not random allocation of participants or workplaces. And these really are before and after studies. So it is a comparison with what occurs after the intervention with the situation before the intervention, usually in comparison to a group in which the intervention has not been undertaken. And a lone before and after study is can only provide weak evidence for an effect. But such studies can be considerably strengthened by being undertaken at multiple time points or in multiple locations, providing consistency of outcome. Could I have the next slide, please? It's helpful to distinguish discrete from complex interventions. In the left-hand column, I have identified the characteristics of a discrete intervention. A single agent confined to the place of work with well-defined outcomes that is not context-specific. This means that there is a greater possibility of generalizability than is the case with complex interventions, where there are multiple causes, frequently both inside and outside the place of work, with multiple less well-defined outcomes, and where relationship can vary in different circumstances. In these cases, they can be context-specific, making it more difficult to generalize. Next slide, please. So I'm going to now give 2 examples of interventions. The first of reduction in exposure to asbestos in reducing the risk of lung cancer mortality. So this is the very famous study published by Richard Doll in 1955, which shows that the risk of lung cancer is some 15-fold greater in this population who were working in an asbestos textile factory in Rochdale compared to the local population, with 11 deaths occurring as compared to 0.8 expected. You'll also see that there is an increase in other respiratory diseases due to asbestosis. So overall, the risk of death in this population, working population, compared to what would be expected, is more than twice as great due to the development of asbestosis and lung cancer. Next slide, please. Now, all the work for all those who died of lung cancer in this population had asbestosis, and they had started employment before 1923. And that is an important, they started employment before 1923 and had worked for more than 10 years before 1933, when the asbestos regulations were introduced, designed to control asbestos exposure for those men working in so-called scheduled areas where the exposure to asbestos was considered to be highest. So the question that needed to be addressed was there a continuing risk of lung cancer in men exposed to asbestos exposure who were employed after 1933 working in scheduled areas? Next slide, please. And this is the follow-up study published by Julian Petto and Richard Doll in 1985 of over 3,000 men first employed after 1933 up to 1974. And in a subgroup first employed between 1933 and 1950, working for more than 10 years in scheduled areas, they showed that the mortality 20 to 34 years after exposure remained twice that would be expected, despite the fact that the levels of asbestos exposure in the factory had fallen very considerably during this period. The conclusion from this is that while the intervention had been effective, it had not been sufficiently effective to reduce the risk, continuing risk of lung cancer in those working with asbestos. Could I have the next slide, please? So my second example is of the increased risk of coronary heart disease in those exposed to carbon disulfide. Carbon disulfide is a well-recognized toxin causing central nervous system disorders in high concentration, but in lower concentration was found in the 1960s to be associated with an increased risk in coronary heart disease and deaths from coronary heart disease. And this was studied in a Finnish rayon factory where they compared the outcome in over 300 men working in the factory compared to a comparison factory in the same neighborhood. And you can see that during this period, the levels of exposure to carbon disulfide fell with the control measures that were put into place. Next slide, please. And following up the mortality from ischemic heart disease in these workers, looking at a risk ratio of the comparison of deaths from those working in the rayon factory with those in a local paper mill factory, you can see that the relative risk of mortality fell from 7 to 1 during the period between 1967 and 1982. Now, in addition to the reduction in the levels of exposure, they excluded all men with hypertension, with risk factors such as hypertension from working in this rayon factory. So it is difficult to be clear which of these two, the environmental exposure or reducing men considered to be susceptible to ischemic heart disease from the factory, was the more effective. But a combination of these two reduced the increased risk of dying from ischemic heart disease and can be considered as an effective intervention. Next slide, please. So the examples of which I have shown you, the two examples there, really are of discrete interventions, although the intervention in the Finnish rayon factory did include exclusion of men considered to be susceptible. The first example which I showed in relation to low back pain is more complex. Low back pain has multiple causes, both inside and outside the place of work. and the relationship can also vary in different circumstances. So I'd now like to, we'll now move on to the more complex interventions, particularly organizational interventions, which Dr. Wild will take you through. But before I leave you, next slide, please. It's worth remembering this comment from Karl Popper, that we can never be certain about the consequences of our interventions. We can only narrow the area of uncertainty. Thank you.
I will pick up from here, and to begin talking about health and psychosocial interventions, I need to refer back to two topics that Tony introduced, those of complexity and uncertainty, as the essence of health-related psychosocial interventions is working with uncertainty. Next slide, please. This is because context is an active participant, both within and between organisations, which leads to substantial variations in response to the same intervention. For example, a self-rostering system intervention that was designed to improve job control exposures had different impacts on job control across 3 different workplace contexts. In one, the intervention reduced the level of control, so made it worse. In another, it increased the level of control, so made it better. And in one, it had no impact at all. Another intervention, using a large group method to improve health indicators through job support, when it was aggregated at an organisational level, indicated no improvement. However, when it was aggregated at group level, there were variations in impact. Those groups where the managers have been supportive of the intervention and encouraged people to attend showed that the health indicators remained exactly the same throughout the period of the study. However, those groups where the managers had discouraged attendance, the health indicators had shown a decrease in health. What this points to is the concept of a boundary condition. Boundary condition is like fuel in a car. It doesn't work if you haven't got the fuel. Sometimes you take the fuel for granted. And I do wonder the extent to which the lack of an outcome in the back pain example is similar to this one around job support. Can't be clear, but it's a question. So understanding psychosocial intervention requires us to accept complexity and work with the uncertainty consequent upon proper attention to context. Next slide, please. So boundary conditions, as I said, they're the resources that you need for an intervention to have a chance of working. Public health interventions have become increasingly clear that people need enough money or enough people that they trust for lots of interventions to have any impact. And if you implement them without those boundary conditions, you're wasting time, energy, and other resources. In a study of leader resources associated with levels of exposure to psychosocial hazards, it indicated that insufficient peer support for leaders and vigour inhibited their ability to mitigate burnout. So the exposure to hazards and the consequence resources available to a leader is a boundary condition for an intervention. Studies of job crafting, which is a widely used technique to improve job control in the workplace, have indicated that part of its effectiveness is that in seeking social resources, we are able to mitigate burnout. So it's not just the reduced control, it's the access to social resources. However, the capacity to access these social resources is inhibited by job insecurity. So job security can become a significant boundary condition. Another area, looking at the way health and safety knowledge has been used in organisations, is very relevant to the increasing use of written health-related toolkits. But knowledge activism, which is people taking toolkits up, interpreting them, making them make sense, talking about them is essential to turn it from shelfware into action. So this knowledge activism, which is often through TU health and safety reps, can also be a boundary condition. So next slide, please. So context is always at play, and there is a growing body of research evaluating the mechanisms in organisations that are relevant to psychosocial interventions. Now, an organisational mechanism is the socio-technical or hierarchical relationships that get activated around any intervention. An attempt to apply a control-based design in such evaluation can increase the value of evidence, as it can function to hide the mechanisms that are in play that are behind the intervention effectiveness. And there is an increasing body of work using this context, mechanism and outcome model. In these studies, context functions as a moderating variable. So it's the factor that either enables or inhibits a mechanism to be triggered. And context variably activates these mechanisms, which are mediating variables. So they're explanatory of the workplace intervention outcome. So the question underpinning this is not what works, as you'd expect for a quasi-experimental or RCT design, but instead what works for whom, in which circumstance. So I'm not going to go into the details of mechanisms here, but the WHEC paper covers, gives an outline of a lot of those that are the most relevant. Next slide, please. So to be able to work with this uncertainty, we need to be very clear about what it is that we are focusing upon. And in this case, it's the purpose is dealing with the exposure to psychosocial hazards. There is a long research evidence that shows there is a clear association between psychosocial exposures and health. Marmot's work with social determinants of health inequality through the Whitehall studies established the relationship between ill health and low job control, and there's been a large body of work reinforcing that since. Felitti, in the study of adverse childhood experiences, evidence that there was a dose-response relationship between adversity and later health outcomes. This has been repeatedly replicated, including for adult exposures. And what's important here is the notion of weathering and the extent to which work-related and other exposures aggregate over time. So the problems that we're seeing now linked to psychosocial exposures have been a long time coming. Further work, which is and adds some texture to this, is Holt-Lundstad's study of factors that can mitigate mortality risk. Excuse me, I need a drink. No, could you go back, please? Yes. This study indicated that social relationships, that social support and social cohesion had more of a substantial impact on mortality risk than individual health behaviours such as smoking, alcohol use or healthy eating. And it's important to understand that the growing recognition of the importance of social relationships on all other behaviours, as is evidenced in the social cure approach that's developed since then. Next slide, please. This acknowledgement of exposure to psychosocial hazards as the focus is embedded in the health and safety exec approach. And 6 psychosocial hazards, demand, support, control, role, relationship, change, are embedded in the standards. The evidence shows that these play out differently in different contexts, and they have been widely applied. And there is increasing recognition that the growing understanding of mechanisms in the workplace will help in ensuring that these have the impact that they need to. This is important as longitudinal research is now giving causal evidence of the slow accident from workplace exposures. The studies listed there are discussed in more detail in the WHEC paper. but there is a clear association between inflammatory biomarkers linked to bad work, bad psychosocial exposures in the workplace through the increase of allostatic load, which is the increased cortisol linked to HPA dysregulation. Next slide, please. So this means that evaluation is not enough. Because context is always at play, we need real-time monitoring when we are engaged in psychosocial interventions for health in the workplace. And this requires two things. The first is a suitably complex theory of change that clarifies both the exposures that we're intending to address and the anticipated organisational mechanisms. Another way of describing this is a set of hypotheses with multiple causality. These then need to be converted into appropriate indicators, again, which cover the psychosocial exposures, indicators of intervention fit, boundary conditions, and an understanding of how the mechanisms are unfolding. In addition, this must resist the tendency to apply proxies for interim health outcomes, such as mental health symptoms or absence levels, as if they are what we're trying to change. This appears sometimes to be done in an attempt to reduce complexity, but it can lead to misdirected efforts. So, because we can predict that any organisational response will be unpredictable, we must monitor. We must treat organisations as we would a patient. Next slide, please. And there is evidence of harm caused by misguided interventions, often linked to an unintended increase in exposure to psychosocial hazards through the intervention. So in Tauber et al., looking at workplace interventions focused on behaviours around eating, showed that the intervention led to worsened health indicators. In this case, victim blaming is in effect exposure to hazardous low control, so it's better to do nothing. The Health and Safety Exec and the IOS studies of mental health first aid indicated that this had no impact on health management. But within the studies, as with many health programs that don't focus on psychosocial exposure reduction, there is a risk of unintended harm through increased exposures, in this case to demand. There's also workplace resources used for no benefit. And one of the other considerations for mental health first aid is a boundary condition issue, because a referral route is implied in first aid, and that is not yet in place either in workplaces or in the wider context. A final example is attempts to reduce absence management as a health intervention backfire. Presenteeism increases exposure and also susceptibility to hazards, and there was also evidence that it indicates that those in low pay and low security jobs are most harmed by this backfire effect. Next slide, please. So, to improve interventions and outcomes, we need to accept complexity and work with uncertainty. The WHEC paper provides a series of questions to guide design, implementation, monitoring and evaluation of psychosocial intervention in the workplace. But broadly, complex does not mean complicated. Exposures. Don't let yourself be misguided by proxy health outcomes. Start small, monitor rapidly, and be prepared to course correct. And if you're evaluating, ensure you can accommodate the need for course correction. Thank you very much.
Thank you very much indeed to both Joanna and Tony for a really clear description of the fantastic work that's presented in the WHEC report. Thank you very much indeed to both Tony and Joanna for spending time with us today. So once again, thanks to both Tony and Joanna for the brilliant presentations, and I hope to see you all again soon.